All right. Good afternoon, everybody. My name is Michael Dark. I am the manager for the Maryland Tobacco Control Resource Center, and I am a clinical research manager in family medicine at University of Maryland School of Medicine. This is our fifth webinar in our series. The topic today on tobacco use treatment and coaching. I will go over a couple housekeeping items, and then we will jump in. There we go. First, I just want to acknowledge the Maryland Department of Health and the Center for Tobacco Prevention and Control for funding the TCRC, allowing us to bring this information to you today and all the other activities that we engage in. So thank you to MDH. Just to note that this meeting is being recorded. We ask that you remain on mute if possible. If you have questions, please enter them into the chat box. If you'd like to ask your question over the microphone later, we could do that. The slides and recording will be made available on our website. I'll show you what that looks like. And then we do ask that you please complete the evaluation that we have for today. This is a QR code that you can scan to take you to the evaluation. I will also post the link in the chat box as well, so you'll have that. This is our website, medschool.umaryland.edu/mdtcrc. You can also just Google Maryland Tobacco Control Resource Center, and that should come up. Our trainings, the recordings and the slides are here under the trainings tab under past trainings. So we do make those available to you. Hopefully you will share those with others or reference them after today. So I'm going to go ahead and stop sharing, and I will introduce our two speakers. So today we have Dr. Janaki Deepak, who graduated from the Seth GS Medical School in Mumbai, India. She completed an internal medicine residency at MedStar Harbor Hospital and a fellowship in pulmonary and critical care at University of Maryland School of Medicine. She's board certified in internal medicine, pulmonary medicine, and critical care medicine, an overachiever. Her clinical and research interests are tobacco treatment and lung cancer screening. She runs the lung cancer screening program both at University of Maryland and the Baltimore VA, and is also the director of the lung cancer clinic at the Baltimore VA and the director of the nicotine health clinic at University of Maryland Midtown. Our second speaker is Julia Malamed, who is a registered nurse and certified tobacco treatment specialist at the nicotine health clinic at University of Maryland Midtown. She's been with the clinic for over 5 years now, I believe. She works with patients and providers to develop evidence-based treatment plans. She also manages patient outreach to support existing patients and to raise awareness among colleagues in the community, and recently completed her MSN in informatics. So I want to say thank you to both of our speakers for being here today, and I will hand the floor over to them.
All right, I'm going to share the screen here. All right, are you seeing it? Okay.
Yes.
Yes.
All right, go ahead, Janaki.
Okay, perfect. So thank you so much for having us here as a part of this TCRC webinar. Again, I do recognize quite a few faces here from today. And clearly you all heard my very passion about this subject. So Julia, I think I do not have the capacity to, oh, I do. So we are funded, the nicotine health practice is funded by the state health, and of course, TCRC also is funded by the state. Next slide, please. No disclosures other than I'm very passionate about this, and I think I've disclosed this in multiple places. I'm happy to be part of this team under Dr. Niharika Khanna. She has been an awesome mentor, and there's this whole group of people who are part of this team, and these are a few of them under the cherry blossom tree. This was at, what is this place called? Fort
McHenry.
Fort McHenry. I'm also having aging issues. I apologize. Next slide, please. Okay, and as you know, Maryland Tobacco Control Resource Center, we can help you with many things like billing, addressing barriers to care, how can we improve our referrals to quit line, referrals to treatment, development of any new developments in nicotine, informing you about that, and also kind of bringing in academic resources for the same. Next slide, please. So I would like to start about why are we in this situation today? Well, we have a lot to blame ourselves for, a lot. So nicotine and tobacco as in smoking, was really, really promoted by us in the early stages. And we as healthcare providers had a lot to do with it, right? Look at the camels we smoked, or the dentists who advised that we need to absolutely go ahead and smoke to have better teeth and everything. Asthma cigarettes, right? Can you think of in 2024, if you go and tell someone with asthma that you need to smoke a cigarette to cure asthma, they're going to send you hopefully right out. But there's a lot of fake news, right? And we are responsible for this fake news. And the same thing was done with our veterans, actually. They gave them a lot of cigarettes to fight the war. And we have the huge problem with smoking, nicotine pouches, and vaping in the military. Next slide, please. And the Marlboro Man, the ones who being quoted even till today, the Marlboro Man never, ever, ever, ever smoked. So this is part of our fake news. And we need to make sure that when we are engaging with people who smoke, that we need to tell them that. Next slide, please. Well, it's not just smoking anymore, right? It's a lot of Zen pouches and backpacks, right? Or other kind of pouches and backpacks. It's a lot of vaping. There are many new ways on how we have decided to make this a much worse situation that we are in. I am not going to be able to address vaping today, and I think there's already been a webinar on vaping. So I'm mainly going to talk about smoking, but a lot of things that I'm going to talk about is going to apply to vaping too, and I'll do that as I'm talking. Next slide, please. So why do people smoke? Or for that matter, why do people vape? But people who smoke, especially with that oxygen cylinder on, especially in the, I know that we captured this data in the VA. I don't think we captured this in the civilian world as much as to how many people burn themselves down while smoking when they are on oxygen. Just for my information, has anyone in the crowd encountered this before, where they've heard of someone who's smoking or who burned themselves while on oxygen? Anybody? Perfect. Do you mind sharing your experience? Just unmute yourself.
Well, I've experienced a couple of different situations. Some with people on oxygen, some with people with lung cancer that come to the local health department to get help in quitting. Half of them come in and say, my doctor told me I had to come here. I don't really want to quit. And you can't do anything about that. It's like you have to want to quit. So.
Well, not really. And I hope to educate y'all on that. So that's going to be my message today, is why are people smoking and why are we telling people that they need to be ready to quit? So that messaging, I hope, is something that we can change after today's webinar. So next slide, please. So why is this happening, right? It's happening because of the magic of nicotine. And it's not just the nicotine, right? Because nicotine is found in many foods. Nicotine is nicotine as in nicotina tobaccum, from where the nicotine is derived, and why we have called this as tobacco for a long time. That nicotine by itself is a very bitter compound. It is a weed killer. It is also found in various food products, like it's found in various foods. For example, tomatoes contain nicotine. But it's what happens to these nicotines in a vape device, when it's in a nicotine pouch, when it's being smoked as a cigarette, right? There are added alkalinizers that make this nicotine much more soluble and convert it to something called as free-based nicotine. This free-based nicotine is what creates all the havoc in the world. That is not the same nicotine that we get from the nicotine replacement therapy, right? So when you give someone nicotine replacement therapy, it is not the same nicotine, right? So if we use the word all nicotine is bad, people are going to tell me, why are you giving me nicotine, right? Like, is there a problem with the slides? Are we able to see the slides?
Yes, apparently, but I don't know why Zoom is being different today.
We are not able to see the slides, or we
We're
are
on the magic happens here slide.
Yeah, that's exactly where I am. I'm not moved from there.
Yeah, slides are still
Perfect.
good. You're good.
Okay, I'm good. Okay. So it's because of the fact that there is a difference between free-base nicotine and the nicotine that is naturally found elsewhere. And you have to think about it like, there are certain bitter compounds which we change. Like, for example, if you take too much of peppermint oil, it is definitely going to kill you, right? But does it mean that peppermint is not used in many of our things? Absolutely. Peppermint is a coolant, right? And that is the synthetic cooling agent that they are finding. We use it in toothpaste. Yes or no? Yes. But the same cooling agent, when we use it as menthol in a cigarette, is much more addictive. So there is our problem, right? So we need to make sure that when we talk about nicotine, we are talking about free-base nicotine, nicotine which is converted into the most soluble form, which creates problems. And where does it create problems? It creates problems in the survival area of the brain. Next slide, please. And what does it do, right? It hijacks your survival instinct. Is that a dramatic statement? No. It actually goes and attaches itself to the acetylcholine nicotinic receptors in the brain, in the ventral tegmental area and the nucleus accumbens. And you're like, that is Greek and Latin. Let me make it very simple. That's that part of the brain which takes all the external stimuli and it tells us what is safe and what is not safe. Jumping into a fire, not safe, not safe. Drinking Clorox bleach by the gallons and bottles, not safe. Those things, those activities and those things are controlled by the ventral tegmental area, and they get inputs on their acetylcholine nicotinic receptors. So the nicotine, the minute you smoke that first cigarette or you vape or you're using a Zyn pouch, that nicotine gets delivered to the brain within 4 and 6 seconds. And when it gets delivered to the brain within 4 and 6 seconds, it goes and attaches itself and behaves like an external ligand to that safety part of the brain. It then tells the brain that as long as you're seeing me, the nicotine from these products, I am the most important thing. You need to feel safe. You need me attached to these receptors. It attaches itself. It increases the number of receptors. It desensitizes the receptors. And it is then responsible for all the pleasure hormones to be sent and all the pleasure signals to be sent from the brain, like dopamine, which is the main addiction hormone, if you will, not hormone, but like the agent for many substances, right? It is then dependent on it. That is why it hijacks your survival instincts. And they have actually done studies, and I'm going to show you one or two studies about this and how it did it. And it creates a compulsion. That means when you tell your patient with lung cancer, who has had this horrible diagnosis of lung cancer, when you tell that patient you need to quit, you're increasing their stress in the brain. And the only way the brain knows how to cope up with stress in these patients is to increase the amount of cigarettes. They do not care about who tells them what. For them, They need to feel safe. They need to feel less stressed. And the answer is continuing smoking. There is connection with emotion, stress, emotion. I'm doing an exam. I need to vape. I need to smoke. And they are highly engineered devices, highly engineered to deliver this free-base nicotine. And smoking and vaping is a chronic disease. It is not a habit. It's not like brushing your teeth before you eat cereal. It's not a habit. It's a disease, and we need to treat it like a disease. Next slide, please. So these are all the connections. As I told you, there is a glutaminergic pathway, a GABA pathway, dopaminergic pathway, and all of these are there between the nucleus accumbens, and the ventral tegmental area, which are the survival areas of the brain. And you can see that in the ventral tegmental area, there are nicotinic receptors. The amygdala, which is responsible for the memory and the decision making, the hippocampus, which leads to long-term memory, and the prefrontal cortex, which is responsible for us executive functioning of the brain. So all these areas are connected, and all these areas are getting signals from the ventral tegmental area. So we are then looking at a brain of someone who's smoking and someone who's vaping, and you realize what is actually happening in their brain. Next slide, please. So when we talk about this negative prediction error or creating compulsion, remember that the VTA, which is the ventral tegmental area, is sending out these dopaminergic signals to the nucleus accumbens. And as long as the nucleus accumbens is getting these signals from when you're using these nicotine products, it's fine. But the minute you stop using it, it starts really creating this negative prediction error in the nucleus accumbens, so much so that it creates a feeling of something not right. It creates a feeling of compulsion and drug-seeking behavior in that shell, and that is what leads to them picking up the cigarette when they are when they are sick, when they have an oxygen on, when they have lung cancer. That is what is leading to it. Next slide, please. It responds, the ventral tegmental area not only responds to the nicotine, it responds to the rate of change of nicotine, right? And what we have here is the cigarette in the round dots. It is the cigarette in the venous blood and the arterial blood, and the nicotine inhaler, which used to be there in the empty round, and the nicotine inhaler again in the square, empty squares. And you can see that when you smoke a cigarette or when you vape a cigarette and the nicotine, see how fast it goes up there, but see how fast it comes down. So it is this rate of change that the ventral tegmental area is reacting to. That is why it is not something which is sustained. If it was sustained, we would have no problem. People would smoke 1 cigarette a day, right? Or would vape less than a cartridge a day. But that is not what is happening. It's going up and it's coming right down. And these are in minutes, but you can see that it's going up in seconds. It's not even taking a long time. Whereas a nicotine inhaler goes up a little bit slowly and it comes down a little bit slowly. So because of that, the actual medicine, which was an inhaler, is not causing the addiction in the brain. It is not causing the need for more and more nicotine coming to the brain. And that is why when people say that NRT causes addiction, it's not true. And the nicotine inhaler was one of our best nicotine replacement therapies, not being made right now because Pfizer does not find a financial reason to make it anymore. So they have it put saying that the resin for the mouthpiece of the nicotine inhaler is not available, just like many other things that pharmaceutical companies do. Next slide, please. This is a very good example in today's world. We will never be able to do it. but this was done long time before. This is a very good example of telling you what happens to the monkeys when they were exposed to nicotine, right? These were experimental monkeys. Every time they pressed the trigger, they were getting nicotine, okay? They were getting lights, strobing lights, and they were getting a little bit of nicotine, but they also got a shock, okay? So they kept on pressing those levers till they died of electrocution, and they would keep pressing those triggers because they would get more nicotine, more shock, more nicotine, more shock, and this happened till they got electrocuted. This is a very good experiment to tell you the compulsion it's creating in somebody's brain. Just remember this when we are talking to people about smoking, about vaping, about Zyn pouches, because this is the compulsion being created in the brain. So when we tell people, you need to quit now, you are creating stress and you are creating compulsions in their brain, and they are going to end up smoking more. So telling people to quit or telling that I am not going to give you treatment till you're ready to quit is wrong, because we are hijacked. This is a substance that has already hijacked their survival instincts, already creating a compulsion in them, and we are adding to the stress. We are not helping them by telling them they need to be ready to quit to then get treatment or stop. Next slide, please. Nicotine is also the only substance which behaves like an Alexa in the brain. And what do I mean by that? This was a neat study done on rats. And they had the rats in the nicotine cage, which was the black and white cage, initially had nicotine. So they had the rats in that cage, so it would come out through those pores. And then they had the rats in the cage, which was bland, blue, but it had no nicotine. So when the rats were getting that nicotine in that cage, they were all hyper, running around, everything. And then when they put them in this photocell, which just had light in it, they were calm, everything was fine. But now they put them back in the black and white cage, but it didn't have nicotine. It didn't make any difference. They were all hyper in there. They were all hyper. They were all excited in there. It just tells you that our brain is constantly, the nicotine attacked brain or addicted brain is constantly surveying where they are. Do you not see cases where people are having their coffee? They'll tell you, I'm having my coffee. I need that cigarette. I'm eating my meal. I need that cigarette. This is why it's happening. It is actually looking at your behavioral pattern throughout, right? In 2024, it's not going to trigger their brain when they get admitted to smoke a cigarette. If they tell you that I was in the hospital for a month, for 3 weeks, I didn't smoke a single cigarette. The minute I came out, I'm smoking that cigarette. This is why it's happening. This is exactly why it's happening. So try when people are telling you those stories, try to remember why it's happening. I tell my patients, this is an Alexa in your brain. It's watching every movement. It is creating your pattern for the day, and it's going to trigger you like an alarm. Like if you set an Alexa alarm, all of us know it's going to tell you that alarm at the exact time, and this will trigger you at the exact time. Next slide, please. So this we have already talked about. It is attached to emotion, motivation, memory, everything. So a lot of painters and artists in the past used to all smoke because it really does improve their motivation, memory, that, you know, the part of the brain which is responsible for all kinds of arts and, you know, music and everything. It does do it. Next slide, please. This is a very good memoir from the Philip Morris researcher, William Dunn. And this was in 1972, 1973. That is the book. You can see it's dated, but At that time, he said the cigarette should not be construed as a product, but as a package. The product is nicotine. Think of a puff of smoke as a vehicle for nicotine. Think of the cigarette as a dispenser of a dose unit of nicotine. Smoke is beyond question the most optimized vehicle of nicotine, and cigarette is the most optimized dispenser of smoke. What happened when Juul shares fell down after the vaping epidemic? Do you know who bought Juul? Philip Morris. What is the most optimized vehicle of nicotine right now? The vape device and things like the Zyn pouch. The big tobacco has bought this message. They have not forgotten this message. We have forgotten it, but big tobacco has not forgotten this message, and they are finding better and better ways to deliver it. Do you all know that the synthetic nicotine, the 6-methyl nicotine, which is more addicting, is available for any one of you through Amazon? You can buy it by gallons, and it can come from other countries. And there is no restriction. There is no passage through customs or anything for it. Anyone can buy it today. Anyone. So you can just imagine in the hands of the wrong people what it's going to do. Next slide, please. Next slide again. One more click. Sorry, this is one of those. And just so that you know that there is a lot of things in that cigarette. And there was a very nice, yesterday we had a wellness counter, I think, at Midtown. And one of our community health engagement workers had this very nice table. Unfortunately, I don't have that picture of that table here, where we're showing what all is inside a cigarette or inside the vape device. There's so much more I can tell you about it. There is a lot of stuff. There are sugars and aldehydes to make it better. There is licorice. There's ammonia compounds. There is levulinic acid. For anyone who doesn't know what levulinic acid is something which was, in fact, very often combined to cocaine, in crack cocaine and many other things, and it can cause a lot of damage to the vessels. It can cause a lot of damage to many parts of the body, can shut down your kidneys. And there are so many added flavors, chocolate, everything else. So the vape device is just a better version of this. It's just a less smelly, more sexy, better tolerated version of a cigarette. So everyone who is using a vape device to stop smoking, we are in danger zones today, because the amount of nicotine that's delivered to a vape device, through a cartridge, is much, much more than what you'll ever get through a cigarette. Much more. A Juul was 20 cigarettes. A Sorin device is 40 cigarettes. Cloud Puff is 40 cigarettes. The Geek, the 1500 pushes of that Geek device is equivalent to 2.5 packs of cigarettes. 3 milligrams of nicotine through a vape device is equivalent to a pack and a half of cigarettes. So 6 milligrams of e-juice is equivalent to 3 packs of cigarettes. That is the amount of nicotine that's going. Next slide, please. It actually causes long-term changes in the brain. It causes neuronal arborization. It increases the density of nicotinic receptors. It increases the sensitivity of those receptors and those ion channels to nicotine. It changes protein synthesis. It changes neurotransmitter synthesis. And this is why even if people stop smoking for 20 years, they can relapse. And we are going to find the same thing with vaping in future. Vaping is in its infancy, so we have not seen the length and breadth of this disease, but we are going to find this in future. Next slide, please. So, you know what? With everything we talk about, there are treatment strategies which are available, right? And part of it is going to be motivational interviewing and addressing their myths with facts and giving them the actual behavioral therapy, and Julia is going to address a lot of that. But part of it is also giving them treatment, because this is a disease. It changes your brain. It's a disease that needs to be treated. It cannot be that, are you ready to quit? And I'm now going to enroll you in something. No, it's going to be, even the people who believe in quit, I don't believe in the word quit, because quit means the patient is only responsible for it. Cessation means the patient is responsible for it. And it is not smoking cessation. It's not you're a smoker. It's not you're a vapor. It is a person with tobacco use disorder, vaping use disorder, marijuana use disorder. It's a disease. It's like obesity. Obesity is a disease. It needs to be treated. Similarly, vaping, smoking, Zyn pouch use is a disease which needs to be treated. And this doesn't matter if it's cigar, cigarillos, hookah, any other form of tobacco or other things that you're inhaling. All of those things are bad. And why are people, you saw in the youth survey, they're using cigars. Black and mild cigars is such a big thing in the Black community. It has flavoring agents. It can even cause things like hypersensitivity and pneumonitis. So it needs to be treated. We cannot take a passive approach to this. We need to take an active approach and start treating patients. The idea is to give them 1 to 2 controller medications. And what are your controller medications? Chantix as a brand name does not exist. So it's Varnaclin now, and it's bupropion, right? Varnaclin, bupropion, and nicotine patch. What are your rescue medications? It's nicotine lozenges, nicotine gum, nicotine nasal spray. Next slide, please. And how do you choose, right? You need to choose what has the best data. And we are going to go over this in a little bit more details. The best data till today is Varnaclin with the nicotine reliever medications. That has been shown to be the best in decreasing the urge to quit, the maintaining stopping smoking, maintaining it for a long time, and it's a safe medication. You can try to see what you start with, right? If your patients are very dependent on vaping and smoking, you want to make sure that you start with a higher double, 2 different medications. It's absolutely okay for them to have Varnaclin along with a patch. And bupropion actually has shown most efficacy along with a patch, not bupropion alone. And then other things, right? Okay, someone has seizure disorder. What has happened with them in the past? You start them on bupropion, see how they are doing, right? Don't give up on a medication. Have a conversation with people who are treating them, right? The seizure threshold, the seizure risk of bupropion is 1 in 1,000, even in people who have known seizure disorder. So we have to have a data-driven, modified as per patient preference and as per patient side effects, right? I assess the patient for their medication interactions, for their creatinine clearance, and how is it going to be for them. The biggest side effect for Varnaclin is nausea. It is not depression. It is not any of those neuropsychiatric disorders anymore. So we need to do it. We need to make sure that we are giving them controller and reliever medications. Next slide, please. So the controllers, the nicotine patch, as you know, are 7, 14, and 21 milligram. Remember, even though many studies say that each cigarette contains only up to 1 milligram of nicotine, it's not true. It depends on not only the number of cigarettes you smoke, it depends on what's your breath hold, what is your puff, how much big of a puff are you taking, how long are you holding it? and it can deliver up to 28 milligrams of nicotine from a single cigarette. That means a 21 milligram nicotine patch given over 24 hours delivers less than a milligram of nicotine per hour. What is the point of using 7 milligrams and 14 milligrams? What is the point? If the patient is having a lot of tachycardia with it, if the patient's having other side effects from it, having headaches, you can understand, but most often those headaches are actually nicotine withdrawal headaches. And the other biggest myth here is they're supposed to smoke with it. They are not supposed to not smoke with a patch on. That has been debunked in 2013, and we are still clinging on to it so many years later. They are not going to die from nicotine overdose when they smoke with a patch on. They will die from nicotine related conditions if you let them continue to smoke. So we use only a 21 milligram patch. We very rarely use any other patches. Several people, pulmonologists and other people who are involved in tobacco treatment, we give sometimes 2 patches for the patients to use because 1 patch is not enough because that's how much they're dependent and their nicotine metabolism is different. And bupropion is 150 milligrams sustained release. Varenicline is 0.5 milligrams starting dose, and 1 milligram is the dose you want to escalate to. And again, this is different. Each patient is different. Nicotine gum, 2 milligram, 4 milligram. We usually use the 4 milligram gum or lozenge. The nasal spray is still available. Thankfully for us in the VA, the nicotine nasal spray is very available. It is not that simple on the civilian side, and insurance don't cover it. And unfortunately, our nicotine inhaler is currently not available. However, you do have the Nicorette inhalator, which is available on Amazon, sold through Kia Pharmaceutical, which is available in the entire Europe. And that is a 15 milligram dose, and that is very effective. So it is available for those who have the resources. We are working with the FDA to try to make this available to all our people in the US, but I do not know what is going to be the trajectory of FDA moving forward. Next slide, please. So again, the main reason you don't have a nicotine pill is because it undergoes heavy first pass metabolism. That means by the time you ingest enough of nicotine for you to get an effect, you will be having side effects. It'll be poisonous amounts of nicotine. So we talked about the patch, the gum. Please don't chew on it. They're supposed to soften it and keep it between the cheek and the gums. The lozenge is not meant to be sucked on. It tastes goddamn awful. It creates a lot of, hoarseness of voice if they suck on it. It's supposed to be parked between the cheek and gums. And we talked about the nasal spray, and the oral inhaler is not available. Next slide, please. Bupropion sustained release. Again, it's a reuptake inhibitor of dopamine and norepinephrine. It is really unclear how exactly it works. It's great for people with depression. It works very well. And again, the average seizure rate is still less than 1 in 1,000. Next slide, please. Varenicline or epovarenicline for a short time, because we did not have varenicline for some time. There is a starting pack when it was there as Chantix. It is safe to take actually for more than 6 months now, but 6 months data is definitely established, and up to 12 months data also is established. The worst side effect is nausea. They need to take it with full food. That means not like I'm running and I'm eating a banana. No, it'll still cause nausea. So you need to have them have a good meal. It's okay even to take it at lunchtime. I tell people, if lunch is your first meal, take it at that time and then take it later on in the day. And it causes a sustained release in the chemical levels, right? And that provides that relief from the nicotine craving. right? And the withdrawal symptoms. So it's like a partial agonist, antagonist, like naloxone in many ways. And it really is really good. Next slide, please. I don't know if I included the slide on the Eagles trial. This is just basically telling you that the base, when you use nicotine replacement therapy with smoking, you're never going to get to the amount of nicotine that you get from just smoking the nicotine. And that is why when I was talking about this morning, that it has been proven, there are Cochrane reviews done on this. The rate of cardiovascular side effects are much more with cigarettes and vaping even than actually using NRT. And there was a great clinical review in one of the cardiology journals, which basically put vaping in the bottom and said that vaping is not good because it does also cause arthrogenesis. Vaping with nicotine causes arthrogenesis, causes all those cardiovascular effects of palpitations and high blood pressure and everything. And there are more and more data coming from both animal studies and anecdotal human experiences looking at this. So please do not think that giving your patients a vape device is the way to go to stop smoking. That is a dysfunctional method of stopping smoking. Next slide, please. And I will stop there, and I will definitely entertain more questions, but I will give this off to Julia now.
Hi, everyone. So today we're going to talk a little bit more about the myths and facts around stopping smoking, vaping, etc. So a common one we hear from the patients and from other people in healthcare is that you need to set a quit date. And that isn't true because, as Dr. Deepak was just explaining, the medications don't work that way. And everybody's going to follow a slightly different process, right, in terms of how they absorb the medications and whether they need to make a change partway through their journey. So the quit date can inadvertently cause a lot of additional stress. Sometimes patients say, well, I set a quit date for my birthday, and guess what happened the night before my birthday? I smoked a whole pack or two overnight. I was so stressed about my quit date. Other things that can happen is the patient feels, oh, well, the medications must not be working for me because I've set this quit date. What's wrong with me? I've got to stop right now. That's additional pressure. Also, it falls into our next myth here about willpower being a factor in stopping smoking. But this is a chronic condition, right? This isn't due to willpower or a lack of willpower. And if that was the case, people would have stopped a long time ago, because we hear our patients coming in and they say, look, my mother died of lung cancer. I'm afraid I'm going to get lung cancer. I have never wanted anything more than to stop smoking. So willpower isn't the issue here. It's that this is a chronic condition requiring treatment. As far as victimization, sometimes I think we in healthcare worry that we're further shaming patients by offering treatment, or that we're putting the blame on them or something like that. But then we're just falling into the trap of delaying treatment rather than helping them. And most patients do want the treatment. As we talked about, it is safe to smoke with nicotine replacement therapy. And this is really a common myth that actually delays people's treatment or derails it entirely, because patients are so afraid of overdosing on a nicotine patch or using too many medications that they aren't getting the best treatment overall. As far as shame, I think we're all pretty familiar with the stigma surrounding tobacco use, especially cigarettes. And patients are aware of these as well. And sometimes when they try to get help for stopping smoking or vaping, they feel more shame than they did before. And shame just prevents them from seeking the help that would benefit them. All right, so what can coaching help with? Coaching can help with things like education reinforcement. As you're probably seeing in this presentation, this is a lot of information, and we're conveying a lot of that in a patient appointment. So the patient might feel like, okay, this is all making a lot of sense right now. I feel comfortable with this information I'm getting from the doctor. And then they get home and somebody says, oh, well, I was told that if you wear that patch while you smoke, you could have a stroke or you could have a heart attack. And then they get scared and they feel like, well, better safe than sorry, right? I may as well just not wear the patch. So the coach has this important role of reinforcing that education, making sure the patient feels comfortable with the information that's been given. Patients may not have other support systems, or their support systems may feel that they're helping, but actually are perpetuating that shame by saying, well, why haven't you stopped smoking yet? Don't you know that this is hurting me too? I don't want you to die, etc. So patients can, use the coach as their support system if need be, or ask the coach to help with building up their own support systems, making sure that their family members have the right information. Motivational interviewing, if you look on the right here, employs some concepts of asking open questions to understand the client's perspective. Everybody's going to be coming from a different background in terms of their own nicotine use, affirm their strengths, reflective listening. When a patient says something, make sure you reflect back to them so that you are both on the same page. Motivational interviewing can also help with eliciting their own motivations for stopping smoking. So most people are probably worried about the health aspects, right? Other people may say, one of my motivations is that I can't spend as much time with my family as I'd like because I'm smoking and my children don't want me around my grandchildren if I'm smoking. Other people may have financial concerns and want the money that they could save by stopping smoking. Others say, I'm having trouble getting a job or something because of my smoking. So whatever that motivation is, it's important to draw it out. Coaching also helps patients with things like insurance barriers. We talked a lot about medications today, and things like Chantix often are the best medication for most patients, but whether your insurance covers it is a different story because insurance doesn't have the same ideas about what might work best for the patient. So a coach can help with prior authorizations and helping patients who can't get the medications covered, pursuing options like the quit line or free sample options, et cetera, good RX coupons. Also, things like side effects. A lot of side effects happen because the medication isn't being used correctly. Dr. Deepak mentioned like hoarseness from the lozenge and stuff. So if you park the lozenge inside your cheek instead of sucking on it, you'll probably feel a lot better and the medicine will work better. Same thing with the patch. If you keep putting it in the same spot every day, you probably will get that skin irritation. Keep rotating it, you'll have a better experience. Addressing triggers. So a common one is coffee, right? You don't necessarily have to give up your coffee, although if you do, that might be helpful. But instead of trying to give up your coffee, have your coffee in a different room, do something else while you drink your coffee. So if you like to smoke a cigarette, drink your coffee and read the newspaper, try going to a different room and reading a book instead, or watching TV or something. And adhering to the treatment plan. Sometimes patients get a little bit derailed when, oh, I'm doing so well, I guess I don't need the medications anymore, right? They worked, great, I can throw them away. Well, that will throw people into terrible withdrawals. So you want to make sure that patients understand the importance of sticking with the treatment plan because it is working, rather than feeling like, well, it worked, I can throw it away now. All right, craving management. There are some things outside of medications you can do to manage your cravings. Things like just delaying and distracting. A lot of patients say that the craving does pass relatively quickly if they just wait, but you don't have to sit there waiting for it to pass. Instead, you can do things like brushing your teeth, having a big glass of water, keeping your hands busy, whether that's things like crocheting, other crafts, using Rubik's Cube, building something. Moving your body, just get outside, ride your bike, even if it's just going for a walk or going grocery shopping, cleaning your house or something. Moving your body can be part of that distraction. Overall, just stay busy. A lot of patients say, I'm only smoking at home. When I go out, I don't even need to take my cigarettes with me. I don't think about it at all. So that's a sign that if staying busy seems to be helpful for you, please lean into it. All right, so if you work for University of Maryland, we're going to quickly review some tools that are available here, and these may look similar to your system if you work outside of the health system here. There is a hot link in Epic. This is the vital signs page where you document patient's height, weight, and blood pressure. And then if you click here, this says edit tobacco use. I know it looks a little blurry here, but if you click there, it takes you to this screen. And this screen has been updated recently, but the gist of it is the same. We're documenting whether patients are currently using a form of tobacco, when they started. The new system is letting you calculate the details of the pack years, even if patients have stopped and started over the years. You can document smokeless tobacco history. And then if you click over here on e-cigarettes and vaping, we don't want to leave that one out. So you can document patients' history with e-cigarettes, vapes, flavors, whether they're using CBD, etc. And then this is all trackable in Epic later. All right, and then if you type smoking into the order box, you bring up the referrals for the Maryland Quit Line as well as our clinic, which we'll talk about in a minute. You can refer to one or both. Obviously, we'd love to have your patients referred to us. And these all go to a work queue for the clinic referrals, and then the Quit Line referrals go to a queue for them as well. And then they will give you feedback on whether they reached the patient, what happens. So if you click on the clinic referral, you see this screen. It's just the pulmonary location now. We've consolidated everything at Midtown. And then if you click on the Quit Line referral, it asks you questions like, what time does the patient like to be called? Are they approved for nicotine replacement therapy? What's the best number to reach them on? Can we leave a voicemail for you? And if you're a provider signing the referral, it will ask you for a diagnosis. It's important to note that anybody working in Epic can pen a referral to the doctor. So if you're a nurse, a medical assistant, a social worker, even if you can't sign the referral yourself, you can enter that in the order box here and talk to the patient about the referral and then pen it for the provider to sign. We're trying to encourage an opt-out approach rather than an opt-in. So instead of saying things like, oh, well, there is this clinic, do you want me to refer you? Just like we would treat any other chronic condition, like if you have COPD, this is just what we do. We refer you to the pulmonologist. If you have tobacco use disorder or nicotine use disorder, what we do is we refer you to treatment. And of course, patients have the option to refuse, but it destigmatizes treatment to make it opt out rather than opt in. All right, a little bit about our clinic. So our clinic is located at the Midtown campus of University of Maryland, where many outpatient services are now. Our clinic director is Dr. Deepak. She's the pulmonologist and the expert in tobacco treatment. We are all trained by Dr. Frank Leone at University of Pennsylvania. He offers a great class if you're interested. It happens twice a year. And then this is our lovely team. And we're also welcoming a new nurse practitioner, Ellie Turcott. Here is our beautiful clinic, new building. So we offer a comprehensive lung health exam. Part of the process of destigmatizing treatment is you are not just getting tobacco treatment when you come to our clinic. You are also getting lung cancer screening if you're eligible. You're getting care for your COPD, your asthma. And a lot of patients, maybe just tobacco treatment alone wouldn't draw them in, but they are worried about their breathing. They are having trouble keeping up with their grandkids, or they'd like to be able to walk a few blocks without stopping. So if that's the motivation that draws people in, all the better, right? Myth busting, as we've talked about, we do a lot of that in the appointment, making sure that patients feel safe with their treatment plans. We also offer free sample medications. Thank you to our state funding. The state does support us in buying nicotine replacement therapy so that we can give it to patients. This helps both with getting patients started right away on the treatment. Even if your insurance covers it, you might be waiting a little bit. Either you have to go to the pharmacy to get it picked up, or the pharmacy doesn't have it in stock, so they have to order it. But if you're sitting in the appointment in front of us and we can give you the meds right now, then you can start wearing the patch before you've even left the appointment. And then that also helps, if you're trying the lozenge, you're not quite sure how to use it, we can show you right there. Again, we offer these combination medication therapies and the coaching. We see anybody age 16 and up using any nicotine product, and we accept most insurances. For accessing the Maryland Quit Line, there are a number of ways to do so. Again, you can be referred by your provider, but you don't have to be connected to a healthcare system in order to participate. You can call yourself. There are a number of different numbers to call here, including the Asian Smokers Quit Line. There's a website to visit there. You don't have to be English speaking, and you can enroll online if that works better for you. And you can also text to enroll. This is a summary of the different programs that are offered by the Maryland Quit Line. So tobacco users, people who are vaping, if you're pregnant, if you have a behavioral health condition, youth are also eligible. You're not eligible for NRT until the age of 18, but you are eligible for the counseling. And then also their web services. Maryland is very generous with NRT through the Quit Line. Maryland residents are all eligible for 12 weeks of free NRT, and it gets shipped straight to their home, so they don't have to go pick it up. And of course, they get the counseling in addition to that. This is a handout that we give out at University of Maryland, just summarizing how to refer an EPIC and some FAQs that we often get about whether a patient is appropriate to refer to treatment, and some questions about whether vaping is an alternative, how much treatment costs, what happens during an appointment. If you want to scan this QR code, we have a playlist set up. This video here is about our clinic specifically, but there are also videos about the products that help with withdrawal symptoms, such as the medications. This playlist is available to anybody who wants to use it. And if you're inpatient at University of Maryland, you can also access it on your TV in your room. So that's it for me. Thank you so much for your attention today. Does anyone have any questions?
Yeah, I think that there were several questions in there.
Rolling in.
I think one of the questions was about the fact that the equivalence of e-cigarette and nicotine. Let me see if I can. I don't think I can. Julia, can you click on the thing that I put, the nicotine equivalent thing that I put on the message, and can you show it up?
In the chat.
Yeah, in the chat I put it in. So I wonder if we can show that, because there were a couple of questions about that, on the fact that they thought that 20 cigarettes in a pack is like 20 milligrams of nicotine, and that's not true, because it actually is more than that. So this was research done in North Carolina, and they published this. We actually obtained this when we went to ATS 2023, right, Julia? Like, that is when we got this data. They had a lovely presentation at the American Thoracic Society, and you can see here clearly on the e-juices and the pods and how many cigarette equivalents are there. And this is why I told you 1 milligram, 1 cigarette is a myth. It really depends on what all they are doing. So the thing that I told you about the nicotine patch and why we never do anything other than a 21 milligram nicotine patch is the same thing as in these vape devices, and see the amount of actual packs of cigarettes. And this is a very important tool to show people who are vaping, right, Julia? Wouldn't you say, when we have shown it to our adults who are vaping, they are scandalized by it. They are scandalized by how much more nicotine. So that is why it's so easy to stop smoking if you're vaping, right? It's something simple. You have just taken an amount of nicotine, freebase nicotine, and you have now converted to so much more nicotine, and the addiction potential of the vape is so much more difficult. I find it hard to actually treat adults who are vaping, and even treat children who are vaping nicotine, because the amount of nicotine they're getting is so much that none of our NRT comes close to it. Chantix is proven. There are studies now which have proven that Chantix is good for vaping. And I think it was Dr. Nancy, what's her name? Julia? Yeah, Regardie, who has published data on that. And unfortunately, the FDA banned cysticycline, which was going to be a plant-based derivative that worked very much like Varnaclid, to help people stop smoking and vaping, and the FDA decided for their own reason that they're not using it. It's being used in Europe, but it's not used anywhere else. And we are available to talk to anyone who wants to set it up, go in a different direction in terms of how do you do it. There was a question about nursing homes and how their patients who are smoking want a break. I have the same thing here. My VA third floor case manager reached out to me on the same thing. And you have to understand their compulsion to want to smoke, right? So yes, everyone should get a 21 milligram patch, but we need so many people educated for this. And we also need to own and understand that we are under treating them. So we definitely need to make sure that we are giving them something other than just the patches. We need to think about giving them nicotine inhale, reliever medications, and or even starting them on Chantix. There are several hospitals in New York who have started that as pilot programs, and they've found that it really works, that they start Chantix as inpatient on patients. And we are working, in fact, on an inpatient discharge menu right now, talking about some of these medications at time of discharge, and slowly, if there is more buy-in, to start this even as inpatients, because we are definitely doing a disservice by not treating them while they're inpatient and they're having all these cravings. And we are saying you cannot go out and smoke. It's a problem. Like if you look at University of Maryland downtown campus, just right outside the main entrance, outside shock trauma, they're all in their scrubs. You recognize a whole bunch of them, and they're all smoking or vaping now. Michael, was there any other questions I didn't address?
Let's see. If you do have questions, you can go ahead and put those in the chat, or if you want to come off of mute as well, that's fine. I do see there was a discussion between a couple of people about standing orders of the local health departments. Yeah, that can be difficult for the cessation programs where your health officer or some other provider has given you a standing order to follow, but the research changes. So that's definitely a good discussion point to bring up about how you can possibly take a look at revamping your programs.
We've been talking about that with the quit line, right? Like, I mean, one of the big problems we have with the quit line right now is that when we tell our patients that it's okay to smoke with a patch on, they tell them it's not okay to smoke with a patch on. And we have had several other things, or they give them lesser milligrams of nicotine patch. So we are trying to talk to the quit line, and I'm sorry, Michael, I didn't mean to cut you off, but we are trying to also see if we can become like the state of Delaware, which provides all the medications free of cost to the quit line. Like the quit line provides all FDA approved medications free of cost. So even Varniclin is available free of cost to everyone. So I hope that can happen. We'll see. Now I'll shut up, Michael. Sorry.
No problem. There's a new question. What are your recommendations for NRT or varenicline for someone who is going through 1 can of chewing tobacco a day?
Yeah, that's about 80 milligrams of nicotine. I think it's a little bit higher. It's like 100 milligrams of nicotine. So this is a patient that you really need to put on both a patch along with Varniclin, because that's a lot of nicotine they're getting, and it takes time, and you have to give them also relievers like the lozenge or the gum. I wish more insurances would cover the nasal spray, because that's very good too. So those are the things you would do. You would do both Varniclin along with a patch. Do you encourage cutting back? Absolutely. Everything you cut back is a win. We never tell people, we do a lot of high fives. If they cut down from a pack to half a pack, high five. If they cut down from 5 to 3, high five. It's always about encouragement. Remember, they've been smoking for 20 years, 30 years, some people 40 years. We cannot expect miracles in weeks. We have to be patient with them. And the biggest thing is engagement with the tobacco coach. For me, my CTTS and tobacco coach is Julia, so it's awesome. But any kind of outreach engagement and also taking the treatment. We have really found that people who are engaged in the treatment and who are engaged with us are the people who actually benefit from this.
It's so common for a patient to come in and say, "They, oh, well, I didn't want to bother you," or "Yes, I ran out of refills, but I just thought I'd wait till my appointment 3 months later," or something. So making sure that patients have your number, they know who to call when they need refills, and that they are always welcomed warmly when they do call is critical.
And I think quite a few of the health departments, even some of the hospitals, use programs like Freedom from Smoking, which are kind of very structured in there's a week where you quit. You have a quit date, you need to stop by that date. And I think that can be discouraging for some people because they aren't able to quit by that date or they slip up or something. So I think, yeah, encouraging cutting back is definitely sometimes a better goal than just outright quitting, because that can be difficult. Does anyone else have any other questions?
If
Either for the
other
chat
health
or
Sorry, Michael. If other health departments want to chime in and work with us on getting our quit line to be like Delaware, where we can deliver all these medications free of cost to all our patients, or all our people who reach out to the quit line and change the messaging, we are more than happy to work with y'all, because I think the more people who are engaged in this and the more people who have had issues with this, and we can bring in real patient information data, right, or client information data, it's more powerful, right? Of course, there's a cost to everything, but you have to also look at the cost of smoking and what it does to health, right? So.
Tobacco companies are always evolving, no matter how little smoke the product emits or how discreet it is, like a nicotine pouch. If it's produced by a tobacco company, they don't have anyone's best interest in mind. They just need you addicted. So patients are always coming in and saying, well, I found this vape and, I heard it's so much better for me, and their hearts are in the right place. But it's so important that we stay on top of this.
Yeah, and remember, if you're sending any patient for lung cancer screening, please make sure they're engaged in tobacco treatment. Doing a CAT scan is not what is going to save their lives. That will save their lives, but that has to be combined with tobacco treatment to save their lives. So please, please, please ask. When we stop using the word smokers and start using different words and stop stigmatizing our patients, maybe then there'll be increased uptake even for lung cancer screening, right? And the problem with lung cancer screening, as I've said multiple times, is we call that, we call that lung cancer, right? So, and there is this lovely message. Thank you, Caitlin, for that. They market themselves as nicotine-free vapes. There's really nothing like a nicotine-free vape. Honestly, nearly always those nicotine-free vapes or the 0 milligram nicotine, when they actually analyze it, the FDA has analyzed several of those. And of course, soon we'll not have an FDA, I think, but the FDA has analyzed several of those, and they found that the 0 milligram can contain anything from 3 anywhere up to 12 milligrams. And we heard today about marijuana, right? And how, I don't know if some of you were there for the talk today, but there was this discussion on how marijuana is wrapped in tobacco leaf, and that is a thing too. So there is many different ways it's getting into people, And we are seeing in our clinic the dual use of marijuana and nicotine is a big problem, a big problem.
All right. I do have one more slide here to go over, and then I'll see if we have any more questions. Right. So I mentioned earlier about our website. The recording and slides will be here on the trainings tab. And I do want to say thank you to Dr. Deepak and to Julia for joining us today. You will have attendance certificates sent by email. I've put the link to our evaluation in the chat. You can also access that with this QR code here if you scan that with your phone. We value all the feedback we get. It helps us plan for future education and see what topics you're interested in or what we need to do differently. So please take a minute or so to fill out that evaluation. It's pretty short. You can do that via phone or on your computer. Let's see. Do we have any last minute questions, either in the chat box or if you want to come off mute? Not seeing anything, so we'll give a couple minutes back to your afternoon, but thank you everybody for attending. Thank you to our speakers and our sponsor. I hope you have a great afternoon, and check our website for the slides and recording, probably either tomorrow or next week.
Thank you, everyone.
Thank you.
Thank you.